Es un placer muy grande tener con nosotros doctora Sandy, que va a hacer la primera palestra porque tiene que tomar el avión. Entonces Sandy va a hablar de Periocular filler and their dissolution. Dr. Sandy Zhang-Nunes, please.
Thank you so much. I'm honored to be here again at this amazing conference. We had an amazing time at Cocobongo last night, and if I have any issues with my voice, it's because we had too much fun there. All right, so I'm Sandy Zhang-Nunes. I'm the Director of Oculofacial Plastic Surgery at USC in Los Angeles, and I'm still working on my Spanish, so please bear with me. I'm going to speak in English. Okay, I have no relevant financial disclosures. So I'm going to quickly go over some preferred periorbital techniques for safety in superior sulcus as well as tear trough filling. Quickly go over some important anatomy, filler complications, ischemic versus non-ischemic, and then how to titrate hyaluronidase dosing for non-ischemic complications. So this gal walked into my office and she actually was asking for a blepharoplasty on her right side, right? And then I pointed out to her, you know, your left side actually looks like there's a lot of hollowing. And to me, that looks more aged, makes you look older. So she agreed that we would do a little blepharoplasty on the right side, and then left side, we would actually do superior sulcus filling. So here's an example of myself filling her sulcus. There is a little numbing injection, and then I prefer to use a cannula for safety reasons because there's a lot of vessels, as you see, that can get in the way. There's the supraorbital and the supratrochlear arteries that we worry about in this region, and of course injury to levator and other structures in this area. So my plane that I'm in is underneath the orbicularis oculi muscle, and I actually try to stay right on top of the orbital septum just for safety reasons. I do know that some people inject directly into the orbital fat in that area. Just to me, it's a little bit more risky. So I go ahead and fill that middle area. I can assess, and then I will actually use that same port to go and inject laterally towards the lateral canthus as well, so to get a more uniform filling. Now she's going to, I actually now only use topical numbing where that bleb is because they don't really need numbing, I think, for the entrance wound. Okay. All right, so this is 2 weeks later. Notice her right brow is a little bit lower baseline. So if you make her brows even, now her sulci match. So it's a good result, and it takes a couple weeks to settle. And then I ask you, which side looks more youthful? The side with more full sulci, or I actually pushed her skin way back just to kind of show her what it would look like if she wanted me to actually match the left side. And to me, that looks as if she's older and more aged. If you look at model faces of these averaged faces from all the big companies, they all have fairly full superior sulci. And as an example, as you see, as the age gets older in these photos, then you see more hollowing in the superior sulci. So it is indicative of youthfulness. Now we'll move on to under eye anatomy. At first I wanted to point it out. Orbital fat prolapse, nasal jugal groove, but the malar edema. I always look for malar edema prior to any injection of filler, any discussion of surgery, because that is always going to be presenting a problem. So I prefer to inject the cheeks more first to see if that will resolve some of the tear trough abnormalities, and you can get good results there. You can also, so I'll do the cheek first, and whatever is remaining, then I'll do the tear trough. And so this is a combination example. So see if I can get this video to play. It's playing. Play. Okay, here we go. All right, so this is an example of filling the lower lid. I first feel for the infraorbital rim and then go for the infraorbital notch. And then I try to go in between. So the infraorbital neurovascular bundle, I used to be taught to go underneath that, but the angle that I'm at right there that I've marked out is, to me, a sweet spot, so you're less likely to go through the infraorbital neurovascular bundle. You can fill medially and laterally through that one port, and I prefer a 25 gauge, 1.5 inch cannula in that area. Okay, filler complications. So best is to avoid them. All right, so you do not want to inject anybody like this with skin laxity, with previous filler. You know who is a good candidate versus a poor candidate. Say no to the body dysmorphic patients. And now for complications, there's ischemic and non-ischemic. So for ischemic, I'll go over that quickly. Here's an example of a patient who was injected in the glabella by her dermatologist a day prior. She presented with this modeling as well as some filler interconjunctival vessels. Fortunately, she was not a case of blindness, but there are certainly several cases in literature. This is a report from Korea showing ocular and nasal ischemia. So, and you see the radius and that's from injection into the nose. And that's the radius in the conjunctival vessels. So we want to avoid that. There's been over 215 case reports actually reported in literature. Of course, we know the numbers must be much higher. And the key really is avoidance first. And to understand the anatomy is really important. So we talked about the supraorbital, supratrochlear, and then the anastomoses from the external to the internal carotid vasculars in nature. So you also have the angular artery you have to be aware of, and the transverse facial, all those arteries. So one way that occurs is actually through a retrograde injection, for example, here through the supratrochlear, then going anterograde and causing ischemia in the central artery, as you guys all know. So management. First, prevention. Know your anatomy, consider occlusive pressure at the notch, consider a cannula, which is less likely to enter a vessel. If you want to aspirate, sure, the aspiration, but be aware that you'll get a lot of false negatives because, especially with thick filler. So some people put air in their hub to try to be able to get a flash response. Consider ultrasound guided, which was nicely demonstrated yesterday as well. And of course, if you have ischemic, you want to flood the area with hyaluronidase. You need to have a 911 kit in your clinic, have 1,000 units on hand. And consider if you actually get blindness, I would treat that as a stroke and send them to the nearest stroke hospital, because that timely fashion is what we need to be talking about, because we've seen too many cases of blindness where this no stroke protocol was activated and they lost their vision, and it's very hard to recover after that. Always have aspirin on hand, consider ocular massage, lowering the IOP, and if there's an allergic reaction or inflammatory reaction, you can also add steroids. What about retrobulbar hyaluronidase? Some people are going to ask you about that. Well, unfortunately, there's papers that have shown rabbit studies where the hyaluronidase does not penetrate through the blood-brain barrier into the optic nerve. So even 3,000 units 30 minutes after it has not shown to reverse blindness, but some people still try. So non-ischemic complications, there's inflammatory and non-inflammatory. Here's some examples of the spectrum. The most common is going to be overfill, all right? And so that's what we see a lot. And really understanding the rheology of fillers, there's some nice papers written about that, is really important. And I noticed that there was a lack of understanding what the filler's responsiveness to hyaluronidase was. So my goal, since I've been seeing, as I mentioned yesterday, a lot more people coming in with fillers that need to be dissolved, causing edema. And first I did an in vivo study to try to see, depending on the filler, how much is best to use to dissolve the 0.2 milliquat aliquots right there. So I used every bump there. I found 9 willing volunteers to get their catnables injected into their arms. And about each aliquot is 0.2, and we injected it with varying doses of hyaluronidase, and starting at low dose, because I kind of wanted to see the minimum dose needed. Because if you do too much, there's also other consequences. And then we had controls as well. And I tested Restylane L, Juvederm Ultra, and Voluma, and found that the L was least resistant, Juvederm Ultra was moderately, and Voluma was the most resistant. And one note was that Restylane L in one arm did last more than 4 years, and it required dissolution later. And I've seen filler last 11 years in patients. They will think they don't have filler there, but they often do. Then I wanted to say, there's so many more fillers on the market. How do we get the data? So I tried to extrapolate the data from my in vivo to in an in vitro method, and this is using. See if my video will play. Okay, so this is using slides, again, 2.2 milliliter aliquots and dissolving them with varying doses and bird's eye view and lateral view photos. So I just want to show you an example here with Bellatero versus Restylane L. So we have, thank you, I'll try to be quick. So you see at 20 units and 3 hours, the Bellatero is flat, but it's still cohesive and you still see the filler there. Whereas Restylane L, you see it dissolves much more easily, it liquefies, and you can see the difference between saving and the Hylenex set. Even at 2.5 units, we'll do something for 0.2. So you can refer to my papers for more detail on this one. And there's more. And you see the key is L and lift dissolve easily. The others do not. And I even added, we went up to 40 units, still there. So then the new study quickly looked at all 21 fillers that we have on the US market, plus some available in Canada. So we have the Restylane fillers, we have the RHA fillers, the Juvederm Ultra, Voluma, and this is about to be published in PRS. And we looked at also videos and graded the dissolution, all right, with all the titrating up all the way to 120. So what we're finding is a lot of these resistant fillers need up to 120 units per 0.2 mLs. So that's a lot. They're very resistant. As you can see, the Juvederm Voluma, RHA4, Volux, all that new products coming out, they're very resistant. And you do have a few on the other end of the spectrum, but most of them tend to be on the more resistant scale. And so this is what I would do. I would start with 2.5 to 5 for most dissolvable, 5 to 10 per 0.2 for moderate, and then more than 20 at a time. It's going to take multiple. So we have a dissolvability spectrum. Now, because I'm out of time, Dr. Holds is going to be going over some example cases of injecting. But this is an example of a patient who wanted me to fill that under eye hollow, but I said, hey, you have this bulge here. And 6 years ago, she had Juvederm, so I dissolved it. I'm going to skip the video, but you can see just doing, and I used my formula to calculate how much to put in there, and just with dissolving, I was able to make both sides symmetrical. So, all right. And then finally, I'm going to skip over these because I'm out of time, but I wanted to also invite you all to our course at USC for oculofacial plastic surgery, and we have people coming from all over the country and the world. To do cadaver dissection. We use everything from lid surgery to orbital decompression, fracture repair, endoscopic DCR, rhinos, and facelifting, endoscopic forehead lifting. So everything functional and cosmetic is there, and it's a great time learning from each other. So thank you very much, and feel free to reach out to me with any questions.
A continuación vamos a recibir al doctor José Raúl Montes, altamente conocido por todos, fundador y director de Facial and Eyes Institute, con un tema que se llama Daddy Do-Over. Gracias, doctor.
Gracias a ustedes. My talk today addresses cosmetic procedures that are trending in my practice as an oculofacial surgeon based in San Juan, Puerto Rico. And in thinking of trends, is the so-called daddy do-over a modern-day phenomenon? Or was the real man ideal nurtured long before any of us were even born? I don't have any financial disclosure, surprisingly, Francois. Okay, superheroes first appeared in the 1930s, capturing the imagination of boys and youth alike, and representing the ideal male physique. They were modern, mythological figures, superhuman gods, and larger than life. Young minds aspire to shape themselves in the image and likeness of their superheroes. And within the pages of those same comic books, the Shahrazad bridged the gap between our human reality and the promise of a perfectly sculpted body, along with the possibility of sex appeal, strength, and self-confidence. Men in the 1960s were not contemplating plastic surgery. A typical male surgical patient would go into the operating table for a tracheal issue, a carpal tunnel, or a knee effusion. Cavity Sam must have seen the Shahrazad ad, probably ordered it, but definitely didn't do it. Fast forward 60 years, a trendy male patient is concerned with his physique, and by virtue of surgical advances, he can bypass the painstaking Shahrazad method to attain his body ideal. Motivations to embrace cosmetic procedures are similar across gender. Ageism affects everyone, men, women, non-conforming gender, and especially old people. That old 20-cent Charles Atlas guide has been replaced by surgical and non-surgical procedures performed by all of you, and a menu that has been carefully curated according to the provider's training, skills, interest, and patient's demands. So let's explore what is trending on males' cosmetic procedures in the US. Daddy do-over phenomenon is a reality across America, and Puerto Rico is no exception.
Just in Washington, D.C., where I treat a lot of male patients. Approximately 30% of my cosmetic patients are men, and by far the number one procedure is PRP for hair loss. Hair loss is by far the number one cosmetic concern in my male patients. Number two most popular cosmetic procedure are lasers. Really lasers for dyschromia, so brown spots and redness. So different lasers, but really to treat the dyschromia. And number three, last but not least, are neuromodulators or botulinum toxin treatments. Treating fine lines and wrinkles, while it's the number one treatment for all patients, in my male patients, really around number three. So I hope that helps give you an idea of my male cosmetic practice.
With a 30% male patient population, Dr. Kinney has a high demand for hair loss treatment. We all know that having a full head of hair brings to a man an almost instant likability and virility. So let's move to the West Coast.
Jason Emmer, and I am a board-certified dermatologist in Los Angeles. 60 to 70% of my practice is men. I do a significant amount of male procedures. Trending in my practice is male body sculpting is huge in my practice, defining the jawline, chin, cheeks, temple area, facial balancing and harmonization with fillers, just giving guys that overall sculpted and defined look, even doing liposuction and buccal fat pad removal to give him that sculpted model look. Male facial sculpting is number two. And then in our practice, we do something really unique. Penile augmentation, we call it down under treatment or girth enhancement. We use both HA and PMMA fillers to build the size of the penis. This is huge in our practice, and not just for guys that are small, also guys that just want a little bit more. I often find that they're greedy, so they want as much as they can get for this treatment. It's huge. So in our practice, we're doing a lot of body sculpting, male facial sculpting, and penile enlargement, and of course, overall facial rejuvenation and acne scars is so patients feel more confident with less scars. Thanks, guys.
Dr. Emmer has a predominantly male patient population, and as he mentioned on his clip, men are coming to gain confidence. His comprehensive approach to male patients goes beyond the face to full body transformation, including penile augmentation. As he said, the girth job is the new boob job. So, time to move to, as the saying goes, no pain, no gain. Time to move to Puerto Rico. At my practice in San Juan, Puerto Rico, when we were published at the PRS Journal in 2015, our male patient population comprised 11% of my practice. 3 years later, our work on men's trends was published on JDD, and our male population had increased to 15%. In our publication, we interviewed over 100 men. Our typical male patient is an educated professional man. This is me bypassing the painstaking Charles Atlas method, and extreme surgery is my own daddy do-over. My male patient clientele clearly shows that the aspiration to look good has no age. The vast majority of men are interested in looking good. One may wonder why the remainder, 25%, were not willing to tell the truth. Interestingly, in my practice, men prioritize facial eye area over body, hair, and skin. And driven by our subspecialty as oculofacial surgeon, most of them are coming for surgical and non-surgical procedures related to the periocular area. That is consistent with the most recent study on the most surgical procedures that are more looked for, in which blepharoplasty ranks among the top 5 surgical procedures. Today, 1 in 5 of my patients are men and is on the rise. Neurotoxins or Botox is still the #1 non-surgical procedure, then blepharoplasty and dermal fillers. This patient of mine, a pediatrician from New York, sent me this before and after himself 2 weeks after his procedure, and he said, "Gracias. My vision has greatly improved, but what really had me jumping on my feet is the way I look." This 90 years old patient, a new outlook in life. And for the typical male patient undergoing surgical procedures, they transcend and move towards fillers or neurotoxins, such as in this case. In our practice, about 50% of men have already embraced the use of neurotoxin. And dermal fillers are second to neurotoxins among non-surgical procedures. In terms of fillers, by an overwhelming majority, male patients are looking to improve the transition between the lower eyelid and the mid-face. Some patients need only dermal filler directly at the tear trough ligament, such as this man, whose after picture was taken 4 years after the treatment. But in many patients, to conceal this transition between the lower eyelid and the mid-face, of course, we need to do more than filling the tear trough. So let's get into the nitty-gritty and explore what I'm doing in male patients with negative vector, shallow orbits, and severe tear trough. This patient with shallow orbits has eyes that look protruded, of course, similar to the negative vector patient. I don't need to tell you what a negative vector patient is, but the mid-face demands convexity. Okay? Remember, for the negative vector, the infraorbital concavity demands convexity. And here, I've been using in my practice for about 10 to 12 years PLLA Sculptra for easing the transition between the lower eyelid and the mid-face. And here, if we have a pointer, Ana Carolina, you can show there where the orbital.
Hold on.
Let me see if this. Okay. No, that's fine. The video. Let's run the video. Okay. Basically, you see there the orbital retaining ligament and the zygomaticus ligament. Between that zone, at the suborbicularis plane, at what we call the SUF, I'm injecting a biostimulant agent, PLLA Sculptra. My entry point is aligned with the iris lateral limbus and is directed to the inferior orbital rim in vectors in anterograde, retrograde direction. The material is deposited in a fan-like technique, depositing the material from medial to lateral and in some cases extending to the lateral canthus. In a patient here with malar edema or a malar festoon, the treatment is being done again medial to the malar prominence, but some of these vectors or material deposition will go through the bone, the hard tissue below the malar prominence, never going into the soft tissue of the malar area, and impacting also the zygomatic arch and the lateral canthus. Basically, this is bathing the whole face of the maxilla from the inferior orbital rim or orbital retaining ligament to the zygomaticus cutaneous ligament, avoiding the soft tissues at the malar area, but impacting the zygomatic arch and the lateral canthus as well. This is me creating a barricade with my non-dominant hand so that I can push the material towards the medial aspect of the infraorbital area. A buttress is created by injecting at this size, and the gradual collagen deposition after approximately 3 sessions spread out in 4 to 6 weeks allows me to even out the topography of that area of the midface, and in many cases improves malar projection and bizygomatic width. On this patient, ligaments effacement, and here a better malar projection. And this is a patient that due to a medical condition was reluctant to surgical procedures, and a biostimulant agent was injected on the lower area as well, and this is after 4 sessions. Remember, this is without surgery. Also trending for my younger patient population, male patients, and also individuals that are transgenders and looking for the stereotypical male features is what I call the testosterone shot dermal filler combo. By selectively impacting specific facial zones such as temples, jawline, and the chins, a more stereotypical masculine appearance is achieved. Here on this patient, the temporal area, as you can see, has a mild concavity, will be impacted with a highly cohesive or high G prime filler with a shotgun technique, 1 centimeter up and back of hyaluronic acid. The jawline will be treated with calcium hydroxylapatite cannula, 25 gauge cannula, in the sub-Q level, approaching also the anterior aspect of the chin to widen the chin, which is one of the features that gives to a man a more stereotypical feature of masculinity. Also the gonial angle to improve or extend the bigonial distance in a man. And then icing the cake, neurotoxin serum in here to complete the treatment. Even a subtle change in appearance has a significant or a tremendous impact on a patient's self-esteem. Masculinity is in constant evolution. Surprisingly, men are willing to share their cosmetic treatments with other people, except perhaps for the penile augmentation. In summary, men's request for cosmetic treatment is trending, and I believe that the most innovative aspect of our cosmetic industry today is that our typical patient is not anymore the middle-aged white Caucasian women. Irrespective of age, gender, and ethnicity, we have all a mutual aspiration, and is to become the best version of ourselves. So those superheroes that once captured our imagination are not that far apart from our present reality. And I take pride of being part of this group of providers that can make those aspirations happen. Practice what you preach. Gracias.
Exercise. And what? Preachers curl.
Thank you, José Raúl. Very nice talk.
Vamos a presentar al doctor John Holtz, que nos visita de St. Louis, Missouri, y nos va a hablar de un tema muy importante llamado The Epidemics of Fillers in the Eyelids, Diagnostic, Treatment and Planning Surgery. Gracias, doctor. Bienvenido.
Dr. Paez, Dr. Borba, and I do want to thank the organizing committee and Dr. Corona for having me here. It's a real pleasure to be here. I do have some ownership interest in Revance, and I don't really talk about their products much, and I wouldn't say anything extra nice about them anyway. But the new aesthetic patient, and this is really based on what kind of walks into my office for consultation, and the use of these hyaluronic acid gel fillers is really ubiquitous, especially in female patients. And my personal record is 14 years for having this surface in someone, so These do stick around. I think the paradigm for many years has been that these will diffuse and degrade in 6 or 12 months. You have to come back and get additional treatment. And now we know that that's completely false. And so you can do an initial appropriate treatment and still get a late complication from migration and degradation. So if there's a question, a trial of hyaluronidase, I've had any number of patients who absolutely swore they'd never been injected or this couldn't possibly be filler, and I look at it and I'm pretty certain it is, like both of these patients. These are very widely employed. You've got all sorts of different people injecting them depending where you are. Somebody might have to be trained at our level, or you might have some nurse or layperson who can inject these products. And they do persist way beyond when they should. This is an Allergan slide, lower right, and I have to say I disagree with this whole Apple concept. And this was from the Voluma launch. So most expensive, most persistent filler, and they used, if you looked at the original study, they used 6 syringes on the average patient, which would be quite a number. But these products do degrade and change behavior over time. These are sculptor nodules in the right lower lid. And this is a woman who's just blown up with hyaluronic acid gel filler. So chronic problem, these products degrade and migrate, and there probably is some clogging of the lymphatics that occurs. The lymphatics are very tiny. You could have extrinsic compression. You can also just fill them up. And when you inject hyaluronidase, you don't necessarily break these products down into individual monosaccharides. They're still linked, and you just have smaller chains, which may migrate faster, but can still clog things up. So there's also a question, I think, of stretching out of tissues. You have these microscopic channels that develop in the tissues, so the SMAS layer and perhaps the orbicularis retaining ligament could be involved. And this can have a significant impact on execution and postoperative course for surgery later in the face, lip, and eyelid. The growth of this problem has been really exponential. The visible filler was probably about 7 years ago present in only about 5% of new patients. I'd say over 60% now have this, and this is in St. Louis. I think if you go to Beverly Hills, it's probably 85%. And so the nail is saying, or the screw is saying, wait, hammer, no. And he says, quiet, nail, because when you're a hammer, the world's a nail. And that's how these products are used. The first report was David Jordan, Canadian colleague, with 3 cases of filler migration. So, this problem's grown so much. I could have 3 new patients on any given day, and all 3 of them have this problem. And one question is this truly Tyndall effect? You heard from Dan Rootman this morning that he and Bob Goldberg published a paper saying that this is not true Tyndall effect. I think it probably is, but there's a question of particle size and so on, and no one's done a study to prove it. But bottom line, it's blue, it's puffy, and it's very recognizable. Patients get multiple treatments spread out over time, and it's very hard to get a history. People come in, they say Juvederm, and I say, okay, which of the 6 products sold in the US are you referring to? Because they're 2 completely separate classes and they behave very differently. Or it's impossible to get records, or the records don't really document what actually happened. And so which product, which tissue plane can be very difficult to determine. And I thought this was important enough when Guy Mastery and I, in 2021, edited a Facial Plastic Surgery Clinic volume. I picked this as the chapter I wanted to write because I thought it was really an important issue and still is. So conclusion on patient evaluation, you want to identify the problem. This is a British woman who actually had seen a whole series of people in the US and in Australia and in Europe and in England. She began with a sort of a bad blepharoplasty, kept trying to fix that, kept getting fillers, more and more was injected. Fortunately, I had about 2 weeks before I operated on her, so this is after her first injection of hyaluronidase. I knew there was a ton of filler in there. This is after the second. She actually liked this better than her original state. And then she produced a photo, and what she was after was not really any classic concept of beauty. She wanted to look more like herself from before, which is unusual. Many of these patients are really dysmorphic and want to look like somebody else. And this was her about 10 days after her surgery, and she's actually been a very good patient and very good to me. So when everything makes sense, you want to inject hyaluronidase, but you usually want to wait until a few weeks before surgery because you hollow these people out and then they just go crazy. I would say Restylane is the long-standing consensus filler. I name names. I think these are all marketed in the U.S. at least as implants, and I can't say high G prime, low viscosity, whatever, and tell you exactly what I'm talking about. I'm just going to call names. I think RHA 1 and 2 are okay. Volbella XC is FDA approved in the U.S. I'd say the Canadians who have used a lot of it for a long time have told me they are less enthusiastic about that. And most people like Restylane because, for one, it's easy to get rid of compared to the other fillers. I use a 25 gauge 40 millimeter cannula, somewhat like Sandy. She gave a great talk on this, as Jose did. And I think you want to avoid, stay submuscular, avoid lumps, etc. So complications, we heard about embolic complications. I'm not really going to talk about that too much, although we do want to be prepared for those disasters, but it's really the overfills that are the problem, and migration and aging and degradation. I think if somebody had Volbella put in 5 years ago, it may not be the same Volbella that came out of the syringe that you're looking at today. And this whole lymphatic obstruction, malar edema. When I get patients like this, I'll inject a little bit of dilute hyaluronidase where her lid's really blue, but she's somebody who's going to just go crazy over any little wrinkle. This woman had seen several people. This was probably about 6 or 7 years ago, and many of them were surgeons who wanted to operate on this, which of course I injected hyaluronidase, and about 2 minutes later it was gone because it was Restylane that was in this plane. Hyaluronidase injection, there's some real issues you have to deal with. This is the witch from Wizard of Oz when my face is melting, but perception drift, Tim Pierce uses the term acclimatization, but people get used to looking weird. And they may want to look weird, but they get used to it. Hyaluronidase in the U.S. is not FDA approved for this, and that would be an issue if you've got a very litigious type patient who's trying to find a reason to sue everybody. People can come in just with a belief that if you inject this, they're going to be worse. Cami Parsa, a long time ago, talked about skin being damaged, especially by Juvederm. And hyaluronidase reveals these underlying damaged tissues, and then Vice, Reddit, and Real Self, which apparently some of my patients think are real peer-reviewed medical journals, their claims of hyaluronidase injury. So this is a woman, way overfilled. I inject some hyaluronidase. I should have stopped right here. She wasn't scheduled for surgery, learning curve. I inject her. I'm like, oh, you look so much better. You're back to your real self. And she completely flipped out and wanted me to refill her the same day, which I told her was not possible. I had to refill her about 5 days later because she was losing her mind, refilled her. She was happy until we operated, but she's a very dysmorphic type individual. Hyaluronidase, there are literature reports using between 9 and 9,000 units. So they're big range. Sandy Zhang-Nunes presented some great data on sort of dosing and how much it actually does take to get rid of this. There used to be a number of different products available in the U.S., but Hylenex, the human recombinant, which is the safest and probably the best, is the only one available now. I will dilute this a significant amount and usually inject small amounts. I think it's better to do multiple passes when you're trying to get rid of a lot. I think trying to get rid of it all in one shot is not necessarily a great idea, and I would not dramatically overshoot how much. You can use ultrasound localization if you have it. I don't, and I've never had a problem dissolving this stuff, so I don't worry about it too much. This is a woman who got a syringe of original Juvederm Ultra, the original class. And she had this injected by a facial surgeon in Maryland. She had seen us actually as a patient before. He injected one syringe, it looked bad, so he injected a second to try to make her happy, which probably did not help things. She's got this skin pigmentation, secondary changes. She'd been seen by us about 5 years prior, so this is what she looked like before. She left things alone. Top photo was her after, I think, 300 units of hyaluronidase the first visit. She got a total of 4 sessions with 750 units, and the bottom photo shows her with this persistent edema, which sometimes that never seems to go away, and she's got a lot of pigment changes. Voluma, somebody in my town likes to inject it. Doctor's wife thought she needed a blepharoplasty. Hylenex, 150 units, better, still has some edema and such along her rim. Another 150 units, better, she's still bothered by a little bit. Another 150 units. I got her down to sort of something resembling what she should look like. Asked her, do you want to do blepharoplasty? No, she was done. At that point, she was just a classic, scared, damaged patient who are bad surgical candidates. I'm going to kind of plow through this. The original Restylane is, other than Velotero, the easiest to dissolve. I think the Hyalocross fillers around the eye, the original Allergan Ultra and Ultra Plus, are just a complete disaster in this area. The Vicross family is hard to get rid of. And I think you need to time appropriately, consider repeat small injections, and again, not an FDA-approved thing. So mid-face filler can be appropriate. Sculptra, Bellafill, and silicone are very problematic. In my experience around the eye, if you put them near the tear trough, José Montes showed using some of this, but you got to remember he's a real expert. So there are things that you tell people not to do that you actually will do. I think fillers can complicate later surgery. Cheek and nasolabial fold can migrate to the eyelid. If you look at this patient, she actually had migration around her canthal angle into the upper lid. Tear trough filling is very technique dependent to get a good even initial result. Usually if you have bad result, do not inject more filler, and remember the paradigm has been completely wrong for years. These persist for years, degrade and migrate, and wait until shortly before surgery. And this is my colleague in town, Mike Nyack, who's a facial plastic surgeon who's brilliant and quite the wit. The Allergan reward program in the US is BD, brilliant distinction, which also might mean body dysmorphia. So he made the comment, I want my patients to have BD just the right amount. Thanks so much.
From the second largest cosmetic market in the world, Brazil, and from São Paulo, we have Fernanda Liedtke talking about autologous fat.
Thank you. Boa tarde a todos. Agradeço a oportunidade de estar aqui trazendo hoje esse caso, que é um caso clínico de enxerto, uma lipoenxertia de gordura autóloga com uma técnica otimizada. Nós fizemos um trabalho com a fração vascular estromal do enxerto, para que o enxerto fosse mais promissor e que fizesse uma pega melhor, para que ele não tivesse uma retração ou uma hipertrofia. Então, nesse caso, foram feito o enxerto, uma lipoenxertia de tecido autólogo, otimizado, com células tronco mesenquimais, retiradas a partir de uma lipoaspiração da região abdominal do paciente. Tudo aprovado pelo Conselho de Ética. Então, este é o caso. É um ciclista jovem que todas as manhãs ele fazia a sua caminhada, os seus quilômetros de bicicleta, e em uma dessas manhãs ele estava em alta velocidade e uma carreta de madeira parou em frente da sarjeta e ele não teve tempo para parar a bicicleta, então dos troncos que a carreta estava transportando entrou na cavidade ocular e ele teve uma lesão severa, ficou em coma por 18 dias e mais um mês de internação, E quando ele foi para casa, ele se recuperou por praticamente um ano. Então, começamos a reestruturação. Primeiro, ele passou por uma cirurgia neurológica para reposicionar, para colocar uma placa na região da área afetada, porque ele teve perda de substância, não só ocular, mas também da parte neurológica. Foi colocada uma prótese metálica pela neurocirurgia. E um ano depois do acidente, nós começamos a fazer a reestruturação da cavidade ocular. Como foi feito isso? Tiramos o enxerto da parte coxofemoral, dentro de um centro cirúrgico, e fizemos uma lipoaspiração manual da cavidade abdominal para retirar um volume para poder fazer essa lipoenxertia regada pela fração estromal de tecido adiposo. Tudo isso cirurgicamente. Então, após a lipoaspiração, tiramos 30 ml do tecido e homogeneizamos em 2 seringas de 15 ml manualmente. Separamos 10 amostras e colocamos para centrifugar as 10 amostras. E nessas 10 amostras, nós coletamos, então, um pellet. Após essa centrifugação, criou-se um precipitado, que é o pellet, onde nós encontramos a fração estromal, bem lá no finzinho, nessa parte vermelhinha do fundo da pipeta. Nós não simplesmente usamos essa fração estromal, nós caracterizamos ela, nós fizemos uma imunofenotipagem, uma viabilidade e a concentração celular nas 10 amostras que nós separamos para a centrífuga. E descobrimos, então, que a viabilidade e a concentração celular encontradas foram bem significativas, foram boas para que ocorresse a pega da lipoenxertia. A imunofenotipagem nada mais é do que um marcador de células de superfície para a célula tronco mesenquimal adiposa. Quando nós fizemos a imunofenotipagem, descobrimos que o CD44, que é um dos melhores marcadores para a célula tronco mesenquimal do tecido adiposo, estava em altas concentrações, acima de 75%. Em seguida, achamos também o CD73, 90 e 105, que também fazem parte do tecido, para o tecido adiposo. Foi publicado esse trabalho numa revista internacional, e temos a evolução clínica do paciente por 5 meses. Nós fizemos essa cirurgia em novembro do ano passado, e até hoje não tivemos nenhuma complicação, nenhuma hipotrofia, nem hipertrofia. Esse é o pré-operatório, após a cirurgia neurológica, o primeiro pré-operatório. Essa é a cavidade que nós tínhamos. Então, nós não tínhamos muita chance de colocar um tecido adiposo extra, porque toda a lipoenxertia tem uma reabsorção de 30%, e a cavidade dele era muito pequena, então a gente não podia ter uma reabsorção significativa. Foi por isso que foi feito esse levantamento, esse estudo, para usar essa fração estromal, para que isso não acontecesse, nenhuma nenhuma hipertrofia. Então, 5 meses depois, nós temos essa foto, essa última foto. Passei, acho que não volta. Essa última foto de acompanhamento. E antes de vir para o congresso, 15 dias antes, nós colocamos a prótese escleral, tendo esse resultado significativamente bom para o paciente. Ele está muito feliz com essa prótese. Então, nós entendemos que a lipoenxertia irrigada, enriquecida com a fração estromal vascular, é um processo que melhora a angiogênese e a deocolagênese do tecido adiposo enxertado, promovendo uma melhora da estética e da pega do enxerto. Obrigada. É isso que eu queria passar.
Muchas gracias, Fernanda. Ahora vamos a escuchar la presentación del doctor Tanuj Nakra, que viene también de Texas. Do you get a yeehaw too? Can we do a yeehaw? No Texans? Okay, fine. Él va a hablar sobre cómo potenciar tu blepharoplastia inferior o los resultados.
Muchas gracias, Carolina. Jorge, muchas gracias. Thank you for inviting me. It's been a pleasure to be here with all of you. I was telling my wife today, this Pan-American group has so much heart, and I really appreciate spending the last day or two with you and look forward to the white party tonight. So I'll be speaking about lower blepharoplasty results and how to enhance them. I'll try not to go over time here. And I'm bringing greetings from Austin. We have a new medical school there, and our TOC team are all faculty at the medical school, and we would invite you to come visit us. We have a growing team, and we're very proud of our recent acquisition, which is Richard Allen, who's joined our team as of this last year. So we're learning as much from him as you are every single day. So when planning a lower blepharoplasty, we have to ask ourselves, where is the eyelid? Is the eyelid right below the eye? Does it extend down a little further? Does it include the cheek? And I would suggest that it really is all of the above. The lower blepharoplasty takes into account the entire lower eyelid and cheek interface, and our responsibility as oculofacial plastic surgeons is to address the entire region. So when thinking about how to put together the right plan for each patient, you got to start with the deeper structure. So the bone structure really helps to decide which pathway we might take for each individual patient. Do they have a negative vector, a neutral, or a positive vector? This is a very important determination right off the bat, because the location of the bone behind the soft tissue really decides the power of the tear trough ligament and the impact it has on the facial aesthetics. There's both skeletal aging as well as soft tissue aging, and it's that bone structure that is the underpinning of some of these changes. So when you look at this, on the left we have a youthful face, and on the right we see an aged face. We see that the maxillary bone has receded. It's pulling with it the soft tissue as well as the ligamentous structures. And so, when we take into account the bone structures, the next layer that we'd like to analyze is what's happening to the soft tissue layers. And there's famous articles by Rorik and his team from about 20 years ago that really delineated all the facial fat pads, which to me, I think is a seminal work for anybody who's doing lower eyelid midfacial surgery, because not only does this give us a roadmap to the fat pads of the face, but it also tells us where the ligament structures are. And so we all know that the lower eyelid orbital anatomy is delineated by the arcus marginalis and the inferior oblique and the lateral expanse of the oblique. But beyond the orbital rim, that's where things also continue to get interesting. We have the tear trough ligament, which is really the attachment of the orbicularis retaining ligament, and it can have different strengths of attachment and different distances of where the orbicularis is sitting in relationship to the bone and the periosteum. And then there's the zygomatico-cutaneous ligament, or the malar ligament, that also interfaces with midfacial and lower blepharoplasty surgery. So we have three basic tools for recontouring this lower eyelid cheek junction. There's fat removal, which is traditional transconj lower blepharoplasty, fat transposition, where we're moving fat into the cheek from the orbit, and then fat grafting or fat transfer, where we're harvesting it the way we just saw and inject it into the midface. So fat removal will reduce orbital fullness. We can also use this as a differential tool if someone has asymmetry. I have patients where sometimes we'll use fat removal on one side and a fat transposition on the other side, or we'll take the fat from the removed section and directly inject it or place it into the other side. So fat removal is a good option for people who do not have a tight retaining ligament. This patient had a little bit of removal along with CO2 laser resurfacing, and we called it a day. It was a beautiful outcome for her, simple recovery, simple procedure. And we don't need to go into the details of how to do fat removal here. I'm sure everyone here is very familiar with the basic techniques of fat removal. Fat repositioning is, from my perspective, really changed the power of what a lower blepharoplasty can do, because now we're really manipulating the ligaments and working in the cheeks. So a patient like this that has a tight retaining ligament, removing fat is going to create a hollow appearance in this patient and not address the tear trough ligament. And so again, when we look at the orbicularis retaining ligament, go back here. Sorry about that. So when you look at the orbicularis retaining ligament, when we release it from the bone, it really allows the orbital compartment to become one with the suborbicularis or the SOOF compartment, and we can move the fat pads around as needed to get the shape and the distribution of volume that we're looking for. And so I like to do a complete release of periosteum that extends all the way from the nasal bone out laterally to the external attachments of the lateral canthal tendon. And this pocket needs to be inferior enough for you to be able to place the fat pockets, and even beyond that, because the sutures are going to be bringing the fat down into that space. And I also like to use this concept of laying the fat edge to edge. So if we simply just push the fat pads down into the cheek, as time goes by and the swelling goes down and you're really critical with your results 6, 12 months later, you'll find that there might be some irregularity or lumpiness. So if we put the fat edge to edge, as you see in the top right image here, really taking the time to construct these pedicles into rhomboid shapes and attaching them in their corners, that's what really produces kind of a smooth outcome. Here's the fat pads sort of laid out for us, before transposition. The medial fat pad, the oblique between the medial and central. And I also like to include lateral fat in the central pedicle if needed in a situation where the lateral skin is not too thin and will be able to tolerate having grafted fat into the lateral region. So, here's a patient who clearly has a negative vector. Ligament surgery is really necessary to get the best outcome possible. So this is going to be a series of videos just showing some of the key steps of a transposition surgery. I like to use a Q-tip and take a preseptal plane down to the orbital rim. And once we're at the orbital rim, we'll take the time to really ensure the orbicularis has been pushed off of the periosteum, especially medially, because the facial nerve branches are traveling on that deep surface of the orbicularis, and aggressive surgery medially can injure the orbicularis. Having said that, it's still very important to release the pocket completely all the way to the nasal bone, because the tear trough goes all the way up into the medial canthal tendon region. So we want the fat pedicle to be able to make that pathway under the tear trough ligament and permanently obliterate it. You can see how inferior and how lateral this pocket is. Again, it's more than we need, but it allows the pedicles to come down smoothly. Now, we're taking the time to separate out the medial and the central fat pads, identifying the oblique in every single case, because it is possible to create torsional issues where you are pulling some of the tissues around the oblique down into the midface, and you can have a torsional diplopia as a complication. In my career, I've had 2 patients out of a few thousand, and I tell my patients that up front so they understand that this is orbital surgery, there's some small risks involved, and those 2 patients were able to have strabismus surgery and address their issues. But nevertheless, we take the time to really separate out the tissues. You can see there's a tether right here that's pulling the oblique, and we're taking the time to release that tether completely so that there is no way that the fat, as it comes down, is going to pull on the oblique. Here's the fat pads ready to go. We've taken the time to create rhomboid shapes to distribute them into the midface, and I've actually marked out the locations of where I want the sutures to pull on each of the pedicles so that it lays out smoothly. We'll start with the medial one. This is a furrow gut on a mini Keith needle that's used for septoplasty that we've recharacterized for using in this case. And it's beautiful in that it goes right through the midface without any issues passing through the soft tissue structures. And I pass the gut suture right through that corner. And this is the medial edge of the medial fat pad, and we're able to externalize this and tie that down. And now we're taking the suture back through the cheek again and attaching it to the lateral edge of the medial fat pad. And once we've passed through this lateral edge of the medial fat pad, we will take the same suture and pass it through the medial edge of the central fat pad. So this is the end-to-end technique where the pedicles are being brought together to create a continuous sheet that lays over the orbital rim, permanently augmenting the space under the tear trough ligament, and permanently basically giving the patient the equivalent of a small tear trough implant because of the orbital fat that's being brought down into the space. And so these pedicles have been brought together and now will pass the suture full thickness through the cheek. And this is why I have deep pockets, because I like to pass the suture down in a vector that's going to hold the pedicles in the right place for healing. I like to remove these sutures 3 to 5 days after surgery to avoid any tracks in the skin. And then we'll take the time to redrape the central and lateral fat composite. We're hoping to present our series of using combined central and lateral fat pedicles at the ASOPR's fall meeting this year. This has been, from our perspective, a really nice way to really get that lateral volume during a lower blepharoplasty as well. Okay, so another technique that can be useful is that we can extend the pocket down medially along the infraorbital nerve where the levator labii spurious muscle sits over the nerve. We can create a pocket along the piriform aperture, and what happens to that fat during an upper blepharoplasty when we cut it out of the medial space? We usually throw it away, right? Why should we throw it away? There's plenty of opportunity to use that fat to fill the midface, and in fact, the Rourke article from 2003 showed us that the medial deep fat pad is the sweet spot of the face. If you have any filler left over after doing fillers or any fat grafting that you want to place, that's always the spot where you're going to get the most bang for your buck. And so placing free pedicles and free fat down into this pocket, especially if a patient has asymmetry, where one side, everybody's got asymmetry, but when you're trying to really enhance a patient's symmetry, this becomes a great tool for helping to create more augmentation on the side that might have less bone projection. So for the sake of time, I'll probably go ahead and conclude here because I know we're running over, but I just wanted to also mention the power of fat grafting briefly, harvesting fat and injecting fat during blepharoplasty is probably the single most high-powered option that you can add to your blepharoplasty practice. Learning how to do fat grafting is not challenging if you're already a filler injector, and the techniques are basically the same, and really allow lower blepharoplasty results to shine when we're adding volume in the periorbital region as well. Thank you very much.
Thank you. Thank you. From Monterrey, Mexico, our next speaker, nuestra próxima conferenciante, Isidora Arroyo.
Buenas tardes. Qué gusto estar aquí con todos ustedes y de nuevo muchas felicidades a todos los organizadores de este gran congreso. El día de hoy les presentaré el uso de fibroblastos humanos autólogos en las rítides perioculares, lo cual se llevó a cabo en nuestro hospital. Como sabemos, el proceso del envejecimiento afecta a todas las capas anatómicas de la cara. Los fibroblastos son los encargados de la generación de colágeno y de elastina y asimismo de la organización de la matriz extracelular. En el 2011, la FDA aprobó el uso de los fibroblastos para el uso del surco nasogeniano. Resultó seguro y efectivo. En el 2012 se propuso su uso en la región periorbitaria y resultó que aumentó la tonicidad de la misma. Se ha utilizado también en cicatrices. Las terapias regenerativas son una alternativa de mínima invasión contra el proceso del envejecimiento. Este es el primer trabajo en México sobre el manejo de las rítides mediante la aplicación de fibroblastos autólogos. Ya existen compañías sobre este cultivo, pero a costos elevados. Si nosotros podemos reducir este costo, podemos ampliar el uso en la población en general. Así también podemos minimizar la exposición a agentes xenobióticos y el riesgo de efectos adversos. y contar con bases científicos para seguir con esta investigación. Creemos que el uso de ellos pueden disminuir las rítides, tanto del tercio medio como superior facial. Esto es un ensayo clínico controlado, aleatorizado, con triple enmascaramiento que se realizó en pacientes del este del Centro Médico Nacional 20 de noviembre en la Ciudad de México, en el periodo de julio 2021 a febrero 2022. Los criterios de inclusión fueron aquellos pacientes que tuvieran la edad de 25 a 75 años y que tuvieran rítides en la región periocular, en la glabela y en la frente. Aquellos criterios de exclusión, pacientes que hubieran tenido algún procedimiento 6 meses previos, como blepharoplastía, aplicación de toxina botulínica, rellenos, peelings o resurfacing. Y pues aquellos que no hubieran cumplido con el seguimiento. Se eligió como sitio la región retroauricular debido a que es una zona que no hay exposición al sol y que no deja una cicatriz visible. Con un punch de 5 milímetros se realizó el sitio de demarcación para estandarizar tanto el diámetro como la profundidad del mismo, ya que teníamos que llegar a la dermis profunda, donde se encuentran los fibroblastos. Se coloca en un líquido de transporte que va a ser llevado al laboratorio, se diseca y se cierra con puntos simples. En la misma intervención tomamos sangre del paciente, la cual va a ser utilizado como suero en el cultivo de los fibroblastos. En este laboratorio de nuestro centro se realiza el exoplante y es un laboratorio de medicina regenerativa. Se coloca el suero sobre cada uno de ellos y posteriormente estos van a ser colocados en la incubadora. Están aquí unos días y podemos ver cómo estos fibroblastos migran del tejido, van proliferando, se van tornando un poco más fusiformes, sus uniones más rectas y más estrechas entre sí, como matriz extracelular, hasta llegar a la confluencia de 10 millones de fibroblastos, obteniendo una suspensión en 1.5 cc de solución fisiológica. Y procedemos a la aplicación aspirando el contenido en una jeringa de 1 cc. Vamos a aplicarlo con una jeringa de 30 Gs directamente en la arruga, formando una pápula para aplicarlo justo en la dermis en alícuotas de 0.05 a 0.1. Esto lo vamos a comprobar con la sobreelevación de la piel. No hay que manipular la zona, ni aplicar cosméticos, ni jabones durante los próximos días. Como resultado, se incluyeron a 10 pacientes, 9 de ellos mujeres, con una edad promedio de 65 años. Utilizamos escalas de evaluación de las arrugas. Estas escalas involucraban si había sido igual, mejor o peor que antes. Hubo una mejoría subjetiva de los pacientes en 9 de ellos y vimos una mejoría clínica en 6 pacientes. No hubo disminución en el número de arrugas. Los pacientes referían que la piel había sido más tensa o que observaban menos apariencia de rítides. Aquí les muestro fotografías antes y un mes posterior a la aplicación. En esta paciente vemos cómo hay una desaparición del festón y cómo hay una disminución de la apariencia de la hernación grasa, así como de las rítides superficiales. En esta paciente vemos cómo hay una homogeneidad de la piel después del mes de la aplicación, mejoría en la pigmentación periocular. Asimismo, en esta paciente vemos una disminución de nuevo de la apariencia de hernación grasa y también de la coloración de la piel. Aquí también vemos una apariencia de disminución de las rítides superficiales. Y en ella vemos mejoría básicamente tanto en la coloración de la piel como en la tonicidad orbitaria, periorbitaria y asimismo disminución en las manchas. Como efectos secundarios tenemos equimosis, la cual se resuelve a los 10-12 días de la aplicación y un eritema transitorio durante la aplicación. Sabemos ahora que este es un tratamiento de mínima invasión, es un tratamiento autólogo, el cual es del mismo paciente, no tiene efectos adversos. Debemos de tener en consideración que el cultivo de los fibroblastos conlleva un periodo de 4 semanas, pero estamos hablando de un grupo de pacientes que promedian los 65 años. Esto cambia en pacientes de 20, 30 años, pero bueno, eso se hablará posteriormente. Hay una mejoría en la piel a pesar de una aplicación y de que es un seguimiento corto de 3 meses. Estamos siguiendo el estudio para tener un seguimiento más amplio. Podemos ya concluir que tenemos un menor costo que el de las compañías que ya existen ahora en México y en Estados Unidos. Es una alternativa para mejoría de la calidad de la piel. No disminuye el número de arrugas, sí mejora la piel y pues obviamente tenemos que aumentar el número de pacientes para este estudio. Me gustaría agradecer a mi maestra y mi muy querida amiga Sara Plazola, que sin ella este estudio no hubiera sido posible. Y pues de nuevo a todos los organizadores, muchas gracias. Y bueno.
Muy bien.
Jorge, do we have time for a few questions? Or, okay, questions from the audience.
O los pueden escribir en el app, José Luis.
I have a question for my right-hand partner here, David Hall. David, just to make sure for people here, most of us don't do facelifting procedures. What is your ideal patient to do a deep plane versus a small plication?
Well, for a deep plane, that would be a younger patient who I would mobilize the entire skin and SMAS as a unit and in a more vertical vector pull. In someone who had more sun damage, what we call dermatoheliosis or a lot of excess skin, then those patients, I would still do a SMAS flap, but I'd also do a more extensive subcutaneous dissection on those patients so that I could pull that vector more laterally and the SMAS more vertically. So it allows me 2 vectors of pull on those patients.
Okay, great. Any other question? Jocelyn Cohn has a question. Microphone to the second row at the center. The lady in pink, please. The trendy lady. Yes.
Yes, sure. The question is, do we always transpose the lateral fat pad, and what are some tricks, because it's technically hard to do? And I agree with you, which is why I didn't do it for the longest time. The one thing that has changed my approach to transposing the lateral fat pad is keeping it intact with the septum of the central fat pad, so it really kind of acts like one wide pedicle, and that allows it to really be nice and smooth as it's draped over the rim. I don't do it on everybody. I look at their bone structure and their skin anatomy. If they've got thin skin and I'm worried that there's going to be visibility of any contour issues, I don't do that. But patients who have a bone deficiency here can really benefit from that fat transposition. And so yeah, I've been doing it more often. Probably about half of my lower blephs are now incorporating a lateral transposition as well.
José Luis Tobilla.
Yes, the famous question of superperiosteal and subperiosteal, that there's this controversy that exists. So the way I look at it is in the medial third of the midface, it's mandatory to be subperiosteal because the orbicularis is attached so tightly to periosteum here that I feel it's the only safe way to do the surgery, especially if you're getting a full release of the tear trough ligament all the way onto the nose. And so I feel that it's very important to be there so you're not injuring the facial nerve. I've seen patients who've had medial orbicularis paralysis involving the upper medial section of orbicularis, the sector up medially, because of the recurrent branch of the facial nerve that comes around. So these are the reasons why I'm really careful to be subperiosteal there. But once we're at the level of the infraorbital nerve and lateral, the periosteum starts to thin out. It's not as important because the SOOF becomes a lot thicker, and for the sake of ease of dissection, usually it turns into a preperiosteal dissection there. So that's sort of how I look at it. I actually would be interested, I know there's other transposition surgeons here, if you have any other opinions on how you manage that issue.
I'm a subperiosteal transposer as well. I do find that there's more hand-holding, more edema with these patients, especially the older
with transposition
they get.
Surgery
With
in
transposition
general.
surgery.
Yes, it does. You're doing cheek surgery, so it's a lot more healing that happens.
Right.
Correct, yeah.
Right. And is there an age limit where you just go,
I think that sometimes the older patients, you're trying to give them just some kind of a simple improvement that doesn't have a lot of complicated healing. And the way I look at it, if they're 70 years old and they've lived with these eyelids that entire time, they probably are not looking for a massive change. And so sometimes a little fat removal and a chemical peel is good enough for them.
Agree.
I think there's a question over there. Párate si quieres.
Yes.
Bueno, claro, este se lleva a cabo en un laboratorio de medicina regenerativa, los cuales también producen tejidos, ¿no? Entonces llevan las estándares de más alta calidad durante el procedimiento. También se realiza un cariotipo antes de que el tejido se va a expandir y posteriormente a la llegada de la confluencia de los 10 millones de fibroblastos. No se inyecta algo que pudiera estar contaminado, ¿de acuerdo? Entonces, a la hora de nosotros tener la suspensión de estos fibroblastos, podemos estar seguros que lo que se inyecta en el paciente es completamente, pues, estéril y propio de él. ¿Sí respondí tu pregunta? Okay.
Tenemos tiempo para una pregunta más. I'm going to do a complex question for you, Tanuj.
One more.
I'll do a double question in one. Dr. Nakra, for lower transfer blepharoplasty, do you always use general anesthesia, and are there contraindications for transposition of fat?
I would say almost never general anesthesia. It's 50-50. Sometimes it's pure local anesthesia where a patient might get a benzodiazepine, maybe a gabapentin and Tylenol, and then we just inject local anesthetic and away we go. But the other half of the patients are having more extensive surgery, especially if there's a brow lift. Then there's local MAC, sedation anesthesia with anesthesiologist. The only time I'm doing general anesthesia is if it's an extended facelift surgery with a lot of time in the operating room where general is safer for the patients. As far as contraindications, I think that we started to talk about it a little bit. It's all patient selection, making sure we're choosing the right procedure for the patient. I think that if someone really can't handle lengthy healing, their expectations are going to be out of proportion, then keeping it simple is a better way to go.
Bueno, como dicen en Puerto Rico, este programa se acabó. Así que muchas gracias. Aplausos a ustedes. Y aplausos.
Quiero agradecer. I want to just thank this extraordinary panel and the speakers. You're all my friends, my family, amigos, familia. Muchas gracias. Two more things. Nos tenemos que tomar la foto nosotros y Todos, vengan, una foto de todos los que estamos aquí, por favor. Vengan todos a la foto. Muy bien, doctora. Felicidades.